Now I am honored to continue our course today by discussing the cancer-associated thrombosis. I don't have any potential conflict to this clause. Our research, you see, this is the VTE is on top of mind of physician or patient, but it is not consistently discussing the risk of VTE at the time of cancer. Yet, patients are often surprised and discouraged upon the presence of both. This is the problem. So, our learning object today, we have to answer 6 questions. What is the cancer-associated thrombosis, CAT? What is the burden of VTE in malignancy? What causes of CAT? Who is at risk of CAT? How do you recognize CAT? How we can treat CAT patients? Then we'll summarize our talk. Regarding the definition of cancer-associated process, when blood occurs in patients living with cancer, it is referred to as cancer-associated process. The start of cancer, then he develops VTE. Maybe VTE to be the first presentation of cancer patient, but the combination of both, it is CAT. It can occur anytime during the cancer journey, and most frequently first 3-6 months after being diagnosed of cancer. Usually it is diagnosed early after cancer diagnosis. Sometimes it occurs a few months later, and it is a common complication that could be prevented. Is it serious? Yes, because it is the second leading cause of death in cancer patients. It has also high mortality rate. Again, it can delay the treatment journey, and it can prolong hospitalization of the patients. And it also can compromise the outcome of the patients. Also, in 1 to 2% of patients develop blood clot, but the risk of developing CAT is not the same for all cancer patients. You see, there's some cancer have a special entity to developing venous thrombosis, but not all cancer are at the same level. This is the iceberg. What's seen is different from what's hidden. And cancer-associated thrombosis, it is not the final destination. We care about the PE. PE is more serious complications of cancer thrombosis related. As you see, this is the relation between cancer and survival. And you see this is to show how it is running upward. And you see this is very important curve saying the years of hospitalization with cancer patients when they are developing cancer, the VTE in all over types about 6%, while the pulmonary embolism occur in about 2%. That means 1/3 of those develop cancer and develop venous thrombosis. 1/3 of them can develop pulmonary embolism. This is why it is very serious problem. Again, those on chemotherapy, they have a relative higher risk, and they may raise to about 13% of patients with cancer, and on chemotherapy, they may have venous thrombosis. Again, this is very important curve, plotting the incidence of VTE and the days of surgery presented in the hospital. If you are going to perform surgery in a cancer patient, it is more and more tedious, and it gives a more time for develop venous thrombosis. That's why, as I said previously, it can be prevented. It is a preventable disease, although it is a very serious disease, but it could be a preventable one. How can we prevent this? Of course, you can get one answer: thromboprophylaxis. This is one step of the answer. The second step: how can we do this prophylaxis? Is it a measure? How we can apply prophylaxis? Can we do prophylaxis for all patients of cancer? Can we apply at the same level? No. There's a risk assessment model. What risk assessment model we can apply for cancer patients? Is anybody can answer my question? What's the suitable risk assessment model that could be applied in cancer patients? Can one of my dear fellows answer this question?
You know, as in our hospitals, the standard is Caprini or modified Caprini, but Corona score for these cancer patients, but it is not enough to depend upon only clinical. There are another laboratory investigations, and so when score is not enough for these cancer patients because the problem is complex.
Thanks, Dr. Adel. This is the perfect answer. It is not a single risk assessment model can apply for these patients. Caprini is a great one, but Caprini, it is a great one when it is applied as it is. The most recent version of Caprini's risk assessment score can be applied for surgical patients. This is great, but in different situation, it has some different applications and the different modalities of this version. Corona score is a very good score, but it can assess the patient of cancer. But when he is going to surgery, we have to add something. Also, the presence of lab, it is another entity. So, cancer patient is a very good candidate to care about and intervene. As you see, this is how it is rising, and we can drop the overall mortality up to 1.7%. This is another very good study done as Million Women study. It is run about in the Million Lady with cancer breast in the United Kingdom, and this is the result. It was great and splendid, and demonstrate how we can measure and demonstrate the prediction of cancer in 1 million lady with different type of cancer. And you see, it is about 1 in every 85 ladies can develop cancer during surgery or just after. This is explanation of the study. The causes, as you see, we have all know this. This is the standard of who is at risk: age, stage of cancer, type of chemotherapy, and race. Let me run over these slides. And this is the Corona score, and as you see, it is a very simple score, and it also provides the way to give the prophylaxis, but it is not applicable for all patients as it is. How to recognize our patient? This is very important. As we apply the score and we are predicting the development cancer, we can recognize our patient and start for giving him lessons and prophylaxis for his cancer. This is the sign and symptoms you all know better than me. And this is manifestation that mimic pulmonary embolism. It is not ideal CAT. And this is the flow chart we can follow. This is very important flow charts we can apply to reach our measures. This is also very important Wells score to not to predict, to diagnose cancer associated thrombosis. This is very important score, can gives you the probability. If the patient have 2 points or more, he is very liable or more liable for VTE. If it has 1 point or 0 point, there is no possibility of venous thrombosis. This is clinical Wells score, which is very important to understand and to apply. This is again a flow chart for the diagnosis and examination of the patient for pulmonary embolism. And again, this is very important issue we are discussing today. How we can treat those patients with cancer-associated thrombosis. Let us start by the Egyptian consensus, the clinical Egyptian consensus of venous thrombosis. This is done by our colleagues in Vascular Society of Egypt, and it was published in Egyptian Journal of Vascular and Endovascular Surgery, and this is the volume. And in this consensus, they give this recommendation. It is class 1A. For patients with cancer-associated deep vein thrombosis, a low molecular weight heparin is recommended for initial and principal phase anticoagulation. This consensus was published by the year 2020. As you see, they emphasize the role of low molecular weight heparin for initial and maintenance therapy for VTE in cancer patients. Again, it has another recommendation, 2A, in selected patients with cancer-associated deep vein thrombosis with malignancy not located in gastrointestinal or gastrourinary system and approved direct oral anticoagulant for initial, principal, and extended therapy should be considered. I think this is a revolution. They opened the way to use oral anticoagulant for the initiation therapy and maintenance therapy and extended therapy for patients with thrombosis in malignancy. I think this is the starting revolution point. And also this recommendation, as it is published in the ESVS recommendation 2020, the same. Again, we have recommendation 1C for patients with active cancer associated with deep vein thrombosis, switching from low molecular weight heparin to oral anticoagulant is recommended after 3 to 6 months of treatment for extended therapy. This is another important recommendation. If you are going to use low molecular weight heparin for initiation treatment, you can switch after 3 months of your treatment. This was written by 2020. And I think it is the starting revolution therapy. Let us see what NICE recommendation said. Also, it is published in 2020. It suggests considering the WAC for patients with CAT and low molecular weight heparin alone or low molecular heparin associated with warfarin in patients unsuitable for the WAC. You see, we have the choice either to use low molecular weight heparin or the WACs. And those who are not suitable for the wax who have to shift to warfarin. This is another revolution. We all know previously warfarin has no role in maintenance therapy of malignancy, but now it has a role if the patient has contraindication with the wax. So this recommendation is great because it emphasizes the presence of oral anticoagulants for maintenance therapy and not keep the patient for life on low molecular weight heparin. This is another revolution. Let's see what's going after 2020. ACCP guidelines 2021. This is a real revolution. We recommend, as you see, it is not suggestion, it is a recommendation. It is strong. What did they recommend? We recommend an oral 10A inhibitors over low molecular heparin for initiation and treatment therapy versus in moderate venous thrombosis in setting of cancer. You see, this is the real revolution. They said the wax is better than low molecular weight heparin for initiation, maintenance, therapy for treatment of CAD. This is the ACCP guidelines 2021 and strong recommendation. I think we have to believe in science and we have to believe in this recommendation. It is also published in Chest, and this is the volume. You can go and read it, and if you can't access, please let me know and I will give you the original version on demand. What we should remember: CAT is common, costly, and potentially fatal complication, most common in the first 3 to 6 months. Patient at highest risk with metastatic disease receiving systemic chemotherapy. Use of risk assessment model to estimate individual risk symptomatic thrombosis. It is important to consider CAT when patient complains of non-specific symptoms. Early recognition is important because highly effective therapies are available. And now it's your time. Please let me know if you have questions. Wow, I'm shivered.
Thank you, Dr. Ayman, for your great presentation. I want to ask you about the cancer in brain, and the patient is prepared for surgery with recent thrombosis. What do you recommend?
Okay, this is a tricky question. Professor Ayman gave me this situation with 3 points. This patient has a brain cancer. This is the first question. It is like that. The answer is the wax. But this patient has cancer with in the brain, and he is prepared for surgery. That means it is a curable cancer. This is great. And at the same time, this patient has DVT, not prophylactic. He has both pathology. He has DVT and he has cancer, and it is a curable cancer. So we are in a rapid time. We don't have to wait till the patient recovers from his DVT. We have the situation, we have DVT, we have a patient with cancer. We are going to perform surgery immediately. Okay, this situation is not written in the recommendation, but I will give my personal opinion. My personal opinion, we have to complete treatment for this patient. The worry if we can apply full dosage treatment, let us see where is the level of the venous thrombosis. It is a cough one. Is it a cough? We can give intermediate dose of prophylaxis together with elastic stocking and perform our surgery. If it is higher, and the main point, we are afraid of embolization. If we have a higher malignancy, higher venous thrombosis, and this patient is going to perform surgery, and of course we can put the patient on full anticoagulation, I think the answer now, we have to put IVC filter as a relative indication for IVC filter. We put the filter to prevent the embolization and give the patient his chance to perform surgery, and immediately we can take our retrieve our filter and keep the patient on full anticoagulation as early as possible and permissible from the neurosurgeon. Thank you.
Thank you, Dr. Ayman. You know that in pediatric malignancy, most departments all over the world are called hematology and oncology department at the same department. If a child has a cancer and deep vein thrombosis, what's your recommendation? Because direct or target specific anticoagulant, because I don't believe in new, because we don't have the new of the new and then new. It is a target specific to active factor 10. And in the future, there is anti-active 11 for arterial and venous. This is not our issue. But for a child, do you recommend low molecular weight heparin and the dose or unfractionated heparin?
Thank you, Professor Adel. But also, I have 2 points for this question. We have a dedicated session for cancer treatment in pediatrics, and it will be run by Professor Antoniani, and he will give all details about treatment of cancer in pediatric age. I think he can give a lot of answers because he is a very well, I'm sorry. He is a very well speaker and he can answer a lot of questions regarding this subject. The second point of the question, what about the wax in pediatric age? I'm sorry for that. But as you know, there are a lot of speakers wants to ask about many questions. I have to postpone my answer to these guys few minutes. Coming back to the question, the wax in children, it is not written in the guidelines, and it is not recommended to be used before the age of 18, as we all know, and as all documents declares. But there is an oral anti-10 how was released in United Kingdom, and now only in United Kingdom they use oral the wax rivaroxaban oral for children.
Yes, and for rivaroxaban also in Germany, Bayer company has a suspension for the children, and they are making Einstein Junior study.
Yes, but the release of Einstein Junior was not published yet.
Thank you, Professor Ayman, for a tremendous lecture. My question is, the ASCO 2019 mentioned the extended treatment for patient with cancer-associated thrombosis. So when the patient is already on chemotherapy, I'm asking about the extended treatment. For how much long we use the therapeutic dose for of 2X with patient already on chemotherapy, and after the stoppage of chemotherapy or after changing to or after he is stop his treatment, does he need to run for a prophylactic doses or just to stop it and use, for example, other physical measures to as a prophylaxis for DVT?
Thank you. It is a very good question. ASO recommendation 1920 published the extended therapy in active cancer, and it defined active cancer as those with rising cancer or those patients who are going on chemotherapy. We categorize the patient on chemotherapy as active cancer. So extended treatment for this patient should be extended as if they are receiving this treatment. This is number one of my answer, or this is the first part of my answer. Active cancer and duration of extended therapy. But when we stop chemotherapy and the patient is quiescent and he is not in an active cancer state, what should we do? Also, it is written in the ASP guidelines 2020, the extended therapy in those with not active cancer should be at least for 1 year. At least extended therapy for 1 year. After that, we can put the patient on prophylactic dose. Please. Professor Korashi is a professor of vascular surgery in Castlehane University, and he has a lot of publication regarding venous thrombosis.
Thank you very much, sir. First, in short, there are some risk factors for the cancer-associated thrombosis. First is the leukocytic count. Some things of the corona scores of the cancer-associated thrombosis, they state that if the leukocytic count is high, and if the platelet count is high, then we should initiate immediately antithrombotic. What do you think about this in practice, actually?
This is a good question. In corona, they said if the patient has high leukocytic count or high level of antiplatelet, one or both are dangerous. If they are combined together, it is very dangerous, and it get 2 points. This is in corona, and from practical point of view, I think it should be applicable. Thank you. Although, if the patient had a high leukocytic count in combination with high CRP or manifestation of infection, for example, this would be considered. I think I don't have more questions. I'm lucky. I'm lucky. Now I would like to end the first session of our course, of the winter course.